All right, so today we're going to talk about respiratory failure. Now, our respiratory system has two sort of big functions: oxygenation and elimination of carbon dioxide. And when that fails in one or both of the gas exchange functions, we call that respiratory failure. So there are two big sort of types, type 1 and type 2. Type 1's characterized by hypoxemic respiratory failure. So your oxygen is lower than 60, but then the carbon dioxide can actually be normal or low. Examples of cardiogenic or non-cardiogenic pulmonary edema, pneumonia, or pulmonary hemorrhage. Then there is type 2, which is hypercapnic. And the way it differentiates is that our carbon dioxide is elevated. And these can be like a drug overdose, neuromuscular diseases, chest wall abnormalities, and severe sort of airway disorders. I think the main this is a very simplified mechanism, but in type 2, the main way that carbon dioxide is elevated is because there is not sort of enough. It's a very globalized issue. It's affecting quite the whole lung, and therefore both functions of oxygenation and carbon dioxide elimination is affected. However, in type 1, only sort of patches of the lungs affected, and carbon dioxide diffuses across the alveoli a lot better than oxygen does. And therefore, because there are still other segments of lung, such as a pneumonia or pulmonary hemorrhage, there are other segments of lung that is still effective. Carbon dioxide exchange can still occur. However, it's the oxygenation that really is affected. But that was a gross simplification of that mechanism. So let's talk about hypoxemia. So that's low levels of oxygen. That's present in type 1 and in type 2. So multiple causes. The two big ones that we really see in ED and ICU sort of settings are ventilation perfusion mismatches and right to left shunting. So ventilation and perfusion mismatches is when there is an abnormality in ventilating of air and perfusion from the arteries. So if we look at our ventilation perfusion ratio in a perfect ideal setting, it should be 1. So that gas exchange can occur. There's enough oxygen in the alveoli. There's enough blood through the capillaries and through the arteries coming through. So it's perfect. Now let's say that ventilation is impaired and that becomes 0 as the most extreme sort of scenario. Then our perfusion is still very good. However, our ventilation is gone, and therefore we can call that in an extreme situation a shunt. In the other sort of aspect, when our perfusion is sort of cut off, but there's enough oxygen in the alveoli, we call that dead space, and we have a very high V to Q ratio. There is also right to left shunting, and it can be mechanical, so cardiac sort of abnormalities like VSD, ASDs. It can be physiologic, so such as in like pulmonary embolisms or pneumonia, where parts of the lung are physiologically shunted to try to optimize lung function. There could be hypoventilation, where there is not enough sort of oxygen going into the lung itself. And there are some other ones as well, but those are the 3 big ones we sort of want to focus today in. So hypercapnia is defined as an elevation in this carbon dioxide. Now, it's really important to know that carbon dioxide level in the blood is directly proportional to the rate of production, which makes sense. The more that's produced, the more there is in the blood, and is inversely proportional to the rate of carbon dioxide elimination. Again, makes perfect sense. The more it's eliminated, but it's inversely proportional. Alveolar ventilation is determined by minute ventilation and the ratio of dead space to tidal volume. So this is sort of an equation that summarizes how alveolar ventilation is determined by, and all these factors, remember, affect our carbon dioxide level. So when there is a change in minute ventilation, ratio of dead space, or tidal volume, they all affect our carbon dioxide level in the blood. So increased dead space, reduced minute ventilation are common causes of hypercapnia. So whenever we have a respiratory failure, it's really important to have a good sort of approach, and that's really through our ABCs, not AB. Yeah. So ABG is a very important one, but I thought that was meant to say ABC. So first, you have to assess and stabilize the airway, breathing, circulation, disability, and exposure as well. But those are the main ones. We can do some brief clinical bedside assessments with telemetries and oxygen monitoring. And ABG can be incredibly helpful in respiratory failure, identifying the causes, and we can do some bedside investigations as well. So let's start with our A for our airways. We want to assess for upper airway obstruction. So our patency, are they talking? Are they having a presence of stride or potential airway compromise? And in respiratory failure, this could be due to maybe results of carbon dioxide narcosis in hypercapnia, or the actual airway could be the cause of the hypercapnia itself. So if there was a foreign body or upper airway obstruction, that can actually cause our hypercapnia. So it's kind of both ways. So we can do some simple airway maneuvers, or even use adjuncts to help us sort of open the airways. And we can then consider things like intubating and having a secure airway later down the track. In terms of B, we kind of focus a lot about oxygen. Initially, we want to aim for about 90 to 93% when we're on supplemental oxygen while we have results pending from an ABG. The absolute lower limits are really unknown, but 90 to 93 is sort of our sort of go-to when we initially start to assess. In rare occasion, if they're very known severe chronic hypoxic hypercapnic levels, then we can aim for about 88% if we know that that's close to their baseline and they're stable in terms of their cognition. So some acute hypercapnic respiratory failure, when they're very high severity, not probably need more than just supplemental oxygen, and we need to think about NIVs and invasive mechanical ventilation. So when things when you consider, NIVs are not for everyone. If they're very hemodynamically unstable, if they have severe impaired consciousness, if they can't protect their airways or secretions, because remember, they're sort of external, they don't actually secure the airway itself, or they've recently had facial, esophageal, or gastric bypass surgery, then they're probably not suitable candidates for NIV, and we might have to consider invasive ventilation. So in terms of C, we really think about our IV access, making sure that they're hemodynamically stable. Things will order in a respiratory failure. ABGs, probably one of our big important ones. We want to get a sort of full range of our common bloods, full blood count, UECs, LFTs, CMP. Depending on the scenario and our clinical sort of judgments, we can order some CRPs, troponins, and BMP. If there is an infectious sort of etiology, we can look at cultures and viral panels. We can also think about ECGs as well, if they're thinking cardiogenic sort of cause. A chest x-ray is pretty much well standard. And then there's some other ones as well that we can consider. Then they're all based on our clinical impression. So let's talk about ABGs. I'll probably make another session just based on ABGs, but basically we want to know what if there is an acidosis or alkalosis, but we're going to talk about respiratory sort of acidosis mainly today, and whether there's a compensation or not. Now, on top of that, compensation is quite important, because sometimes we can have mixed acidosis when there's a component of respiratory and metabolic. So how do we know if it's hiding or not? So there's a good table on the right-hand side that shows us that, let's say in respiratory acidosis in an acute setting, every rise in 10 of the PCO2 level, the HCO, so bicarbonate, should rise by 1. But in a chronic sort of setting, it would rise by 3 because there's already an elevated bicarb. Because our kidneys have had time to adjust. So some compensation going on. Now, if there's an acute on chronic, then our measured pH is going to be a lot higher than what we expect. But in just a pure acute acidosis, you're going to measure your hypercapnia and bicarb, and it accurately predicts the pH. There's a lot of formulas based on this, but in terms of an examination sort of setting, probably just needing to know how to do the basics of an ABG is probably the most important. Now, in terms of ABG, we can also calculate what's called an AA gradient. That should be a little a. Our AA gradient basically tells us if this is a lung problem or if this is not a lung problem. So, for example, if in a type 2 respiratory failure, you've got high CO2 levels, low oxygen levels, how do you know, just based on an ABG, if this is like a neuromuscular sort of issue, or whether this is something like COPD that's affecting the whole lung itself? That's how our AA gradient comes in. It tells us how well the gradient is between the alveolar and the arterial sort of side. So if this is an intrinsic lung issue. So let's look at various causes of respiratory sort of failure. So VQ mismatch. So we talked about VQ mismatch, and this is a lung issue. So you're going to have a high AA gradient. Typically normal PaCO2 levels, because there's still good segments of lung that you can probably perfuse through, and it responds relatively well to oxygen. So here's our formula calculating AA gradient. So it's pretty much alveolar oxygen minus arterial oxygen. Now we know our arterial oxygen because that's what we collect from our ABG, but our alveolar oxygen is calculated through the alveolar gas equations. So it looks pretty complex, but a lot of this is already known. So FiO2 levels is usually 21% on room air. This one is a sort of a fixed value, but on sea level, but it can vary depending on where you are. This is also a fixed number as well. So you can actually summarize this as a constant. And so really, this is the only one that sort of changes. Now, other causes of respiratory failure, we talk about right to left shunting. And they have, because this is a lung issue, you're going to have a high AA gradient and a normal PaCO2 level. Usually these are not usually oxygen responsive. Hypoventilation. So this is reduced minute ventilation. So you're thinking neurological, neuromuscular. So it's not really affecting our lung, except for airway disease. So let's ignore airway disease. We're focusing mainly on sort of external factors. So they're going to cause a normal AA gradient. Usually oxygen responsive, but it doesn't resolve hypercapnia. So you give them oxygen, it's not going to bring down their CO2 levels. So the only way you're going to get the CO2 levels down is to increase their minute ventilation. And that's when we think about NIVs and intubations. So this is all about sort of initial management, and definitive maintenance therapy is really depending on what the underlying cause is. Remember, respiratory failure is not a diagnosis. It's sort of a syndrome or a broad sort of aspect. It's sort of an idea rather than a diagnosis. Now, we also need to know our disposition of a patient. So when do we think about ICU? So there's no agreed criteria other than things like need of NIV and intubation, but other common reasons are if they need frequent monitoring, if they need a fine titration of their supplemental oxygen, or prolonged application of NIV. Other sort of indication you think about severe impaired consciousness. So we're thinking they might progress into an intubation, respiratory muscle fatigue, or severe acidosis. Even so, if the etiology is usually easily reversible, needs sort of minor supervision, or doesn't even need admission, then there's probably no need for an ICU admission. And usually you should always discuss this with an intensivist, respiratory physician, or neurologist as well. So we'll talk about a few case scenarios. So look, 63-year-old woman arrives in ED in respiratory distress. Paramedics who transported her were not able to obtain any information. They found a bag of medications. This includes aspirin, torvastatin, metformin, furosemide. On examination, her temperature is normal. Blood pressure is quite elevated to 20 on 112 and heart rate of 130. So what would you like to do next? So take some time to pause and sort of think through what your management will be. And then I'll talk about what we will do in the next slide. So first of all, you want to go through your examination, and you do that initially through an A to E assessment. So we're going to look at our airways. We're going to have a look at the breathing, have a listen to the lungs, give supplemental oxygen if required. So having a look here, we don't really know the oxygen level, but we're going to give it if as required. We're going to establish IV access, send off bloods, order relevant investigations, going through each sort of approach of the A to E assessment and stabilizing the patient. So while we're doing that, we notice that the skin is cool and clammy. She's alert, but can really only answer yes or no questions. She's got jugular venous distension to the angle of the jaw, so quite raised. Rales to both lungs, pre-tibial edema bilaterally, and her heart sounds are regular, although tachycardic with an S3, S4 gallop. So what it sounds like is she's got some pulmonary edema, most likely, just given the edema in the legs, rales in both lung fields. And it sounds like a cardiogenic cause, just given the raised JVP and the tachycardia with the gallop, and also given her medications that she's on as well. Aspirin and torvastatin might signify that she has underlying cardiac issues or a raised risk of a cardiovascular event. So what we'd like to do next, so probably have ordered our relevant bloods, and we'll probably want to analyze that. We want to order a chest x-ray as well, and that can give us a greater idea as well. So initial assessment, move patient to a monitored bed, even simple things like positioning patient up, A to E assessment, basic investigations, and an ECG will be very helpful as well. Make sure that BNP, brain natriuretic peptide, which can be very raised in heart failure, and chest x-ray. So let's interpret this chest x-ray. So you want to go through a system, but just given our time constraints, we're going to sort of talk about major abnormalities in the chest x-ray. We can see that there is quite a lot of congestion, sort of spaced out primarily in here, and we call this sort of like a bat wing appearance. It's very hard to discern a typical bat wing appearance, but usually it shows that it's mainly sort of in like a wing-like distribution. We can see that it's mainly sort of perihilar regions, called patchy opacities. We can see some upper vein diversions. It's hard to assess the cardiac border just because this is an AP film, but it does look enlarged, but a PA film is very appropriate only to assess the cardiac border. And in terms of the costophrenic angles, it's hard to discern on the left, but it seems to be clear on the right. Other things that we can sort of maybe pick up is there might be the presence of curly B lines, which might suggest some interstitial edema. So treatment, positioning. So we talk about it as a POND, acronym P-O-N-D. P stands for positioning, and we can even consider some positive pressure ventilation. O for oxygen, N for nitroglycerin, and D for diuretics. And they're our mainstay treatment for acute pulmonary edema. Previously, it used to be Moan, I think, and that used to incorporate morphine, and morphine was very good in lowering preload, just the same as how we use nitroglycerine. However, morphine had some association with increased mortality, increased rates of intubation and ICU admissions, and therefore it's really taken out of our mainstay treatment. So let's go through a second case. 35-year-old woman presents a severe asthma being seen in ED. On a previous admission, she was transferred to ICU for the treatment of asthmatic exacerbation. For the past week, she's been using her rescue medications a lot more than normal, and nighttime exacerbation every second evening. So it's a pretty big red flag. Her oxygen saturations are 92, very high arrest rate. She's quite tachycardic, and an elevated BP as well, with some pulses paradoxicus of 10. So what is our important step in managing? Again, the same sort of thing. We want to first start off with moving the patient to a monitored area. We want to position the patient. And when we want to position the patient, because they're in respiratory distress, we want to position them upright. And then we're going through our A to E assessment. So we'll go through airways. How is our airways? Is she talking? And if she is talking, how much can she talk? She's talking short sentences. Is there presence of stridor? Is the airways itself patent? Then moving on to B, we're going to look at she's oxygen saturated 92%. So we can probably start her on some oxygen, supplemental oxygen. But ideally, remember, we talked about 90 to 92%. So she's already in that okay range for now, but we want to maybe think about starting on some slight supplemental oxygen and just monitoring that. Probably want to have an auscultation of the lungs itself. See if there's bilateral air entry, see if there is any sort of additional sounds that we can hear. And in terms of investigations at this point, we can order a chest x-ray, a mobile urgent chest x-ray. Then we can go through our C, circulation. So we've got our blood pressure, our heart, which is quite tachycardic. Let's check her perfusion in her little limbs. Want to check her pulse. We want to check if she's any sort of central or peripheral cyanosis. And establish some IV access and both hands. Would also like to collect some bloods. So we're gonna get a standard sort of lab profile. So for blood count, UECs, LFTs, we'll get a CRP. There's some sort of inflammation that could cause this, that triggered this exacerbation as well. And we'll also like to get an ABG or a VBG as well, and that can give us a good idea of our acid base, and that's probably one of the most crucial investigations from this point. And in circulation, people can consider things like ECGs, which probably less likely in this case. And then we'll go through D, looking at her alertness. Is she actually talking? How is she in terms of her consciousness? Is she able? And that can really tie in with the airways as well. And E for external. So looking if there is any sort of rashes, how is there temperature? Is this an infectious sort of etiology? And things that we might miss as well. So looking at the abdomen and going through a thorough examination. So we found that she's in acute respiratory distress. She's got expiratory wheeze throughout both chests. So I'd like to order some investigations, and we get our ABG. So we can see that our pH is sort of now considered acidosis. And we kind of look at what segment is causing the acidosis, and it's quite clear that it is the PaCO2 levels that are causing the acidosis, which seems to be slightly elevated. She's also quite hypoxic, and her bicarb level is sort of just in the higher end of normal. So in terms of the calculation of the AA gradient, would use these measurements. So put in FiO2 level, atmospheric pressure 760, and H2O, so water, it's going to be 42. And we put in the values of our PaCO2, and that can help calculate the AA gradient. Now, the normal AA gradient will vary based on age. So age divided by 4 plus 4 is usually the standard formula. It's usually about 5 to 10 plus age-related changes, because you got to realize that as you age, our lung function deteriorates naturally, and therefore there's going to be some differences, some VQ mismatch. So in terms of the chest X-ray, so again, we're going to just identify some basic sort of structures. Here you can probably see some collapse of some of the lung lobes, probably in the left middle zone, possibly in the right upper one as well. There's some perihilar changes. The lung itself looks to be slightly hyperinflated. We can count the ribs to confirm that, and some flattening of the diaphragm as well. Usually would get a bit more of a curved sort of image. There is no sort of focal consolidation that we can see. And you could probably make out some bronchial cuffing. So this looks like probably some collapse of some lungs due to mucus plugging. And the hyperinflation, this it's quite typical of what we would see in an asthma sort of exacerbation. So treatment-wise, oxygen, we can think about salbutamol or any sort of SABA, and that can be given every 20 minutes. And then we can add on some anticholinergic agents. But also want to start on systemic corticosteroids, given that this is already a quite severe episode. And then that's probably our mainstay of management. And then we can add on therapies based on how effective it is. So if it's still having little or poor response, we can add on some IV salbutamol. We can also consider magnesium, and things like theophylline and aminophyllines less used now because of their narrow therapeutic index, because given their side effects of cardiac arrhythmias and tachycardia. Now, if there is still very poor improvements and there's deterioration even, then we can escalate to things like NIVs, IV ketamine, and as a last resort, sort of rapid sequence intubation and ventilation. So let's say in this case, a patient is not improving. She's only speaking in yes or no questions. A repeat APG shows worsening of a respiratory acidosis. You listen to a chest, it's very quiet with some very distant wheeze. So this is definitely big red flags. Quiet chest or silent chest is things that alert us that the severity of asthma itself. So just think that if the wheezes are loud, doesn't mean the asthma, it doesn't correlate well with asthma severity. So contact a senior, discussion with the respiratory physician, anesthetist, do an A to E assessment. So every time there's a clinical change, go back to your A to E assessment and go and correct any reversible changes. Think about escalating your oxygen delivery. And given sort of the worsening picture, this could be an indication for mechanical ventilation. Last case, 43-year-old woman struck by a car or some sort while crossing the street, sustained bifrontal cerebral contusions, right peteal fracture, left-sided rib fractures, and a splenic laceration as well. So they're all managed non-operatively. On day 4, she's now developed some respiratory distress. Her blood pressure seems to be okay, quite tachycardic, high risk. She's quite tachypneic, but her GCS seems to be fine, not GSC. So you're called in to evaluate and manage the patient. How will you manage this patient? So again, we'll go through all the simple things: moving the patient, positioning the patient, A to E assessment, collect your relevant bloods. And given every time you go through a case, think about sort of what could be happening. So she's quite tachycardic, tachypneic. We don't know her oxygen saturations, which should have been given, but that's fine. And she's now day 4, given a quite significant automobile accident. So thinking most likely this could be things like DVTs and pulmonary embolism. So that should be on the back of our head. We can also think of some other differentials. So this could be things like a pneumonia. This could be things like, this could also be things like a bleed or sort of hypovolemia, but her blood pressure seems to be okay. Could this be anemia? There's a wide range of differentials, but just given this topic on respiratory failure as well, that's something that we need to look for. So now, given that that's sort of our main differential, given the extensive sort of orthopedic conditions that they've had, probably she's quite immobile. I'm not sure if she's received any prophylactic therapy to prevent DVT prophylaxis. But given that, should we get for a D dimer or should we get for a CTPA? Well, in this case, just given that there's a lot of risk factors, we would probably go for a CTPA, and there's a good criteria to help discern that. There's the Wells scoring criteria for PE, and that can go in risk stratify patients, and based on their risk, it would conclude whether you need a CTPA or whether you need a D dimer to rule out a PE. I think given that PE is our main differential, and given that she's already has a history of immobility and being in hospital, I'm not sure about a past medical history, whether she's had one before, or whether there has been any recent malignancies, or if there is any symptoms of calf tenderness. That could also add in some extra points. But just based on those first two ones, she already probably classifies for CTPA. So we do an ECG, and this is her pattern, what seems to be going on. So here we can see, we can probably see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 6 is about 66 heart rate. She's not tachycardic. So now let's look at the axis deviation. So number 1, I always look at number 1 and AVF. So AVF is sort of positive. And number 1 seems to be negative. So this is a very strong, probably right axis deviation and an extreme axis deviation. If we could probably look at her QRS complexes. So we've got our P waves, and that seems to be quite okay. And now QRS complex seems to be quite widened. And if you look at the M sort of characteristic, this is very typical for a right bundle branch where there's an M and they say that it should be a W. Or you can even think about it as a positive sort of V1 and an M sort of wave suggests marrow, as they call it. It's a marrow, M for V1, W for V6, because M and W. And what does it spell in marrow in the middle? RR, so right bundle branch block. Other things are there is inverted T waves, particularly in the precordial leads, and the initial ones from V1 all the way to V4. So, and there's a very dominant VR wave, V1, sorry. And there's poor R wave progression, I would say. And you can also probably kind of distinguish, there's also some T wave inversions here and a very deep Q wave. This is something called the S1, so S1, can you see a deep S wave? Q3, there's a Q wave in number 3. And T3 is an inverted wave. Now, the S1, Q3, T3 suggest pulmonary embolism, but is only present in a very small percentage of patients with pulmonary embolism. And it's not really a very specific or sensitive sign, but it's something quite interesting to pick up in sort of an academic sort of setting. So, so there we have it. So I think we established all of those. Now, in terms of the chest X-ray, there's nothing sort of major going on, maybe a lot increased interstitial marking, some perihilar region changes, possibly some sort of pacification, but really largely I'd say it's quite unremarkable. So we do a CTPA given our risk factors, and there we have a big, quite filling defect, actually bilaterally. So we've got some ventricular strain on ECG, bilateral pulmonary emboli, and she's quite tachycardic. So what shall we do? So in terms of treatment, anticoagulation is usually indicated for stable patients, but she has a very high bleeding risk factor. So we probably don't want to start her on some anticoagulants until we discuss with a hematologist and probably also the orthopedics as well, and maybe even neurosurgeons as well, and then neurologists. So we need to consider the bleeding risk factor versus the stability of the pulmonary embolism. Now, if anticoagulant is contraindicated, we can think about an IVC filter. But let's say now this patient now starts to become unstable. Now, if she had an acceptable risk bleeding sort of complication, we can think about fibrinolysis or thrombolysis. But if there is a high bleeding risk, then we need to be more specific, and we can't give a systemic thrombolysis. Probably need to think about whether she'd be able to receive catheter-directed thrombus removal, or maybe even surgical embolectomies, or catheter even directed thrombolysis, to minimize systemic bleeding risk. So that concludes our topic on respiratory failure and our sort of broad approach. I think I would suggest going through ABGs and knowing how to interpret them. And I'll make another session in the near future, hopefully soon, to go through that. And I hope you guys enjoyed the session. If you have any other topics that I'd like to cover, put it down in the comments. Don't forget to like and subscribe, and I'll see you guys next time.